Hi, welcome. My name is Minakshi Mishra and I'm a PhD student in Health and Clinical Informatics at Oregon Health and Science University, Portland, Oregon, USA. Today I'll present results from my narrative literature review to highlight the role of informatics in implementing guidelines for chronic opioid therapy risk assessment in primary care. The objective of my review was to gain a systems perspective of opioid prescription for chronic pain in primary care, including tasks, tools, processes, and outcomes, and to highlight the gaps in the system that can be bridged using informatics solutions. The roadmap of this presentation will include understanding the significance of the problem from opioid prescription, understanding the landscape of prescribing opioids and risk assessment in primary care, and identifying the gaps that need informatics solution using well-known socio-technical, cognitive, and implementation frameworks. According to the data from United Nations Office for Drug Use and Crime, USA leads the world in annual prevalence of prescription opioid use. Since 1999, deaths involving prescription opioids have increased by more than 5 times, and over 200,000 people have died from prescription opioids. Rise in opioid-related overdose deaths parallel with increased prescribing of opioids for chronic pain. Primary care providers, or PCPs, manage most chronic pain patients and prescribe about half of all prescription opioids. Prescription opioids clearly have a role in the current opioid crisis in USA, as 1 in 4 person prescribed opioids misuse them, and 1 in 10 develop opioid use disorder, also known as OUD. 1 in 20 who misuse prescription opioids transition to heroin. USA is in the midst of opioid crisis, which has seemed to have gotten worse during the current COVID-19 pandemic. Approximately 16 million people worldwide and 2 million Americans live with OUD, which is defined as a problematic pattern of opioid use, leading to clinically significant impairment or distress. OUD is associated with considerable morbidity and mortality. People with OUD are at 10 times higher risk for death than general population. In 2019, prescription opioids were involved in approximately 20% of the death from drug overdose in the US. The cost of reduced quality of life from OUD and lost life due to fatal overdose is estimated to be close to $1 trillion. In order to address these issues, there exists a complex system of guidelines, structures, and processes in place to guide treatment of chronic pain and assess risk for OUD. The 2016 Safe Opioid Prescribing Guidelines by CDC recommends that PCP perform following tasks to assess patients' risk from prescription opioids. Use validated risk screening tools like Opioid Risk Tool to assess risk for opioid abuse. Review patients' medical history in the EHR for illegal drug use, history of substance use disorder or overdose, mental health conditions like depression and anxiety, sleep disordered breathing, and concurrent benzodiazepine use. Check urine drug screening results to confirm the presence of prescribed substances or absence of undisclosed prescription drug or illicit substance in the urine. Review patients' pharmacy dispensing data in Prescription Drug Monitoring Program or PDMP. PDMP is state-run maintained database of pharmacy dispense of controlled substances. Obtaining prescription opioids from multiple providers and or pharmacy can indicate problem opioid use. The guidelines also recommends that PCP identify patients with OUD and direct them to treatment. Here is the conceptual model I developed of various structures, processes, tools, and outcomes involved in the prescription opioids for chronic pain in primary care. This systems view captures the relationships, information flow, and interactions between the different systems involved in the high-quality chronic pain management, opioid risk assessment, and opioid prescribing. This includes the implementation and adherence to guidelines, the clinical setting, order entry, and public health systems. Our PCP integrates data from disparate sources, validated risk screening tools, EMR, UDS, and data in the PDMP to make risk versus benefit decisions. Failure to properly assess and address harm can lead to adverse outcomes like opioid misuse, OUD, diversion, and worse, opioid overdose. This system level view serves to highlight the socio-technical aspect of chronic pain management and demonstrates current and potential opportunities for the application of informatics to improve quality of care while decreasing provider burden. It served as a basis to explore current complexities, bottlenecks, and pain points in opioid prescribing and risk assessment. To more fully characterize these challenges and opportunities, we conducted a narrative review of relevant literature. A narrative review aims to qualitatively summarize the literature with the intention to gain broader perspective on a topic. The scope of the review was opioid risk assessment in patients with chronic non-cancer pain within primary care setting. I included scholarly journals from PubMed and Scopus and official recommendations from healthcare and regulatory organizations. Three frameworks were used to synthesize the findings: the socio-technical model for health information technology, the Cabana framework, and the Paris framework. Let's briefly look at the dimensions of this framework to understand their relevance for gap analysis. The 8 dimensions in the socio-technical model for health information technology by Sittig and Singh are specifically designed to address challenges when designing, developing, implementing, using, and evaluating health information technology within complex, adaptive healthcare systems. These dimensions include hardware and software computing infrastructure, clinical content, human-computer interface, people, workflow and communication, internal organizational policies, procedures, and culture, external rules, regulations, and pressures, and system measurement and monitoring. The Cabana framework draws upon the social cognitive theory to explain barriers to physicians' adherence to practice guidelines. It identifies elements from 3 dimensions: knowledge, attitude, and behaviors that can be modified to improve guideline adherence. PARIS stands for Promoting Action on Research Implementation in Health Services. This framework for implementing evidence from research assumes that successful implementation is a function of evidence, context, and facilitation. If we were to design and implement informatics intervention to encourage guideline adherence, identifying gaps and opportunities along the dimensions from these 3 frameworks will be highly useful. This is a graph of all literature used in the gap analysis. On the x-axis are the dimensions from the 3 framework, and on the y-axis are various risk assessment elements from the literature that map to these dimensions. There is some overlap between the dimensions in the 3 framework. External rules, regulation and pressures, clinical content, human-computer interface, workflow and communication, system measurement and monitoring, and internal organizational policies, procedures, and cultures can be viewed as sub-dimensions or part of facilitation. Similarly, internal organizational policies, procedures, and cultures and people create context. Knowledge, attitude, and behavior are sub-dimensions of the people. The people in our case include PCPs. All the black stars represent positive literature on selected dimension, while the red stars represent literature that touches on current gaps in knowledge and provide opportunities for improvement. Here are the results from the literature review. The findings in red are gaps and opportunities for informatics intervention. Due to time constraints, I will highlight some of the findings in the next few slides and refer you to my paper for the full list of gap analysis. Let's look at the evidence first. The CDC guidelines maps to the evidence dimension of Paris framework. Most recommendations in the CDC guidelines are based on very weak evidence, type 4 or type 3 at best. Incorrect implementation of these guidelines may lead to unintended consequences. There is insufficient guidance on how to safely taper patients on long-term opioid therapy, mainly because comparative effectiveness of different tapering protocols have not been sufficiently studied. There is no widely used risk assessment tool that accurately predicts or identifies misuse and abuse, and applying DSM-5 criteria for OUD diagnosis in chronic non-cancer pain patients on long-term opioid therapy has proven to be difficult. Potential informatics interventions include clinical decision support tools that combines patient preferences and provider experience with the evidence in the guidelines to deliver evidence-based care. There is need for observational studies that use real-world data in the EHR for comparative effectiveness of different opioid tapering protocols and alternate pain treatment methods. Machine learning algorithms can be used to more accurately predict opioid related harms, and there is need to develop OUD criteria or phenotype that more specifically applies to patients with chronic non-cancer pain. The EHR maps to the clinical content and facilitation dimensions of the socio-technical model for health information technology and Paris frameworks. Clinical content in the EHR, such as clinical notes, lab results, and observations, can support clinical decision making. However, variable and inconsistent documentation of opioid use, abuse, and aberrant behaviors can degrade clinical content and lead to missed opportunities to prevent abuse and direct treatment. Smart forms can encourage consistent and systematic documentation of patient risk factors and drug related behaviors. The human-computer interface influences how provider interacts and extracts information from the EHR and the PDMP. Creation of patient registry and EHR dashboards improve human-computer interface and facilitate workflow and communication around risk assessment. Non-intuitive display of PDMP data and lack of interoperability between EHR and PDMP create barriers to using PDMP data effectively and efficiently. Interoperable information systems and well-designed human-computer interfaces are needed to facilitate risk assessment tasks at the point of care. Outcome measures and standard terminologies map to the measurement and monitoring dimension of socio-technical model for health information technology. Measurement and monitoring are essential for understanding outcomes of guideline adherence and for facilitating long-term adoption. Developing and adopting clinically relevant outcome measures will encourage provider adherence to guidelines. The contribution of long-term opioid therapy for chronic pain to current opioid crisis has been difficult to estimate due to lack of standard terminologies and codes for problem opioid use and long-term opioid therapy. One systematic review identified 14 unique variations of long-term opioid therapy definitions across 34 studies. Standard terminologies and code will enable better analysis of outcome and improve our understanding of the contribution of prescription opioids for chronic pain to the current opioid crisis. It will also help in assessing comparative effectiveness of alternate pain treatment options and different opioid tapering protocols. So in conclusion, barriers to guideline implementation exist at many different levels. Knowledge and information gaps are opportunities for informatics intervention. The risk factors in chronic non-cancer pain patients on long-term opioid therapy are multi-component and dynamic. They can change with disease progression, tolerance, changes in pain quality, mental health, comorbidities, other drug therapies and drug interaction, and changes in the patient's lifestyle. When data from the screening tool is enhanced with the EHR data, PCPs can better differentiate the low-risk population from high-risk population. There is a caveat. The EHR data should be of good quality. In order to reduce opioid-related morbidity and mortality, the U.S. Department of Health and Human Services launched a 5-point strategy in 2017. One of the strategies is to improve the public health data on opioid overdose. Similarly, better EHR data is needed to understand and prevent prescription opioid misuse and abuse in chronic pain population. Large-scale federated data sources are being used for population-level estimation and patient-level predictions. However, bad data quality is a significant barrier to these lofty goals. There is a need to identify a minimum set of data that inform patients' risk from prescription opioids and improve its documentation in EHR using standard terminologies and vocabularies. Doing so will better inform patient risk, help us understanding and prevent bad outcomes, inform future policies and guidelines, and truly create a learning health system. I would like to acknowledge my research advisor, Dr. Weisskopf, and my DAC member and mentor, Dr. Piggott, for their help in this work. And thanks to the National Library of Medicine for funding this work. Thanks for listening.